Hello, everyone. I'm Bárbara Melão. I'm an oncologist, associate faculty, and we're here today for another episode of Hearing Out podcast with the great Danny Mena, which is a nuclear physician from Mexico. Danny, welcome to our podcast. It's a pleasure, a great honor to have you here. And I would like you to introduce yourself and talk a little bit about Urotetraglatan, which is a great initiative that you have.
Thank you. Thank you so much, Barbara, for your invitation. I am Danny Mena, nuclear medicine physician, now living in Mexico. I love diagnostic and I love education. And I think that part of building a very healthy environment about diagnostic is about join all the pieces. So that's why 3 years ago, we founded Urotetraglatan, that is, for now, the biggest diagnostic prostate cancer and GU educational platform all around Latin America. So we have urology, oncology, and nuclear medicine physicians inside of that. And the only mission is about education to get a better diagnostic treatments in Latin America.
Great, amazing. I have the honor to be part of this amazing multidisciplinary team that Urotetraglatan has. And well, let's start discuss theranostics. We had great presentations at Big ASCO this year, and I would like to start with BULLSEYE. BULLSEYE was a very interesting phase 2 trial that randomized oligometastatic, oligorecurrent hormone-sensitive prostate cancer patients up to 5 meds to receive after curative intent PSMA PET, lutetium PSMA, or deferred ADT. I think the rationale was to defer ADT, and it will be like a third line therapy after radical prostatectomy, after radiation therapy for the patients before ADT. And I would like to make some comments about BULLSEYE's trial. And
Yeah,
the study
Barbara,
was positive.
yeah, I think that the rationale below this is very simple. You are you are talking about a therapy that depends of the overexpression of some protein on the prostate cancer cells. So in the middle of that, when you begin doing many treatments, any of them, this glycoprotein gonna be worse. So if you have something that is not working well, deleting or damaging this glycoprotein, so then you will have less expression of this. And the rationale below this is that actually when we are talking about RPs, treatments and sequence of RPs and everything, and in the middle you want to do lutetium therapy, you know that this is also happening. So the rationale is because also remember that with lutetium, you're going to have 4 to 6 cycles. But what we are seeing right now is that when we are using earlier the lutetium, the affinity of PSMA lutetium is bigger. And because of that, the radiation that you're receiving from lutetium is bigger. And then maybe many of these patients are going to be super responders that are going to have 2 to 3 cycles and no more than that. So I think that is just a matter of understanding how lutetium is treating this. And because you need a highest uptake, if you have in the middle any situation that's gonna delete this affinity of PSMA lutetium, so then the radiation that you're receiving is less and the results are worse.
Great. And that's the rationale also for PSMA-4. PSMA-4 is approved now, it's FDA approved. So to use PSMA before chemotherapy, after on ARPI, but before chemotherapy. Unfortunately, in Brazil, we don't have this approval yet. I don't know in Mexico.
Actually, in Mexico, we don't have available Pluvicto. We're going to have it the next year. But as I understand, the indication will come with PSMA-4.
Oh, great.
So
Great.
if that gonna be the way, I think that gonna be because in my daily practice, actually I compare the post-chemo and pre-chemo patients, even high volume with viscerals or liver mets in these patients, and the results are pretty different.
They are different. So it's better to get lutetium PSMA as sooner as possible. And
Why?
that's what we're seeing in the trials. They are bringing lutetium early on in the setting, and the results are just great. So another very interesting trial that was presented was Violet trial. So I would like for you to explain first what is an alpha emitter, beta emitter, and the terbium presented in the Violet trial. The terbium is a beta, emits beta particles, but also auger electrons. So please explain for us what are the differences and why auger electrons should be better to treat micrometastatic
I think
sites.
that Violet is pretty interesting because, you know, when you're talking in nuclear medicine, everything is going too fast. We are talking a lot of molecules and more radioisotopes. So for you in urology and oncology field is crazy. But what is the big difference that you need to understand between lutetium and terbium? Lutetium and terbium both at beta. So the beta energy, the radiation, beta energy radiation for treatment is almost the same. But what is the big difference between lutetium and terbium is that terbium have some outer electrons that are some kind of particles that can give radiation 360 degrees. So because of that, the energy that they are giving is higher. Actually, if you compare with this kind of outer electrons, you can treat micrometastasis. And because of that, some people compare the energy that is given between lutetium and terbium, and is 4. So you are talking that if you are giving some unit with terbium, you're going to have fourfold of energy. So it's higher, it's more toxic for the cells. And of course, if we begin trying and developing some more molecules that are going to have less affinity on some special organs like salivary glands, that situation that maybe could be some adverse events that you don't want to have it. So then we're going to resolve and going to jump faster.
Oh, great. So since it's more effective, it has the same treatment-related adverse events, but more frequently, or are there any different adverse events?
Probably going to be worse because especially in xerostomia, maybe could be higher. And one of the things that you are caring about lutetium treatments is about especially the salivary glands and maybe bone marrow that maybe could have a worse toxicity. And now I think that the bio trial will try to understand how many cycles, how much activity of terbium you should give. But for sure, I can tell you that in the toxicity to the cells, terbium is higher, is bigger, is more toxic than lutetium, and maybe a huge interesting future will come in that way.
Great. Well, at Violet trial, patients were randomized to receive terbium. Actually, already have received 1 year PI, one take SEM. So it's a landscape that it's not PSMA4. It's actually vision trial after all these treatments. And it has been shown that it's also really effective even after all those therapies.
But you know right now why? Because diagnostic has a pretty interesting concept. It's between high affinity for PSMA and high toxicity of the radiation that you're using. So if you have a bigger affinity of PSMA, you will have more molecules inside of that cell. And if your radiation is higher, the toxicity gonna be better. So then you will be more deadly for the tumor cells. And of course, you want to take care about the normal organs and take care about the affinity of these cells to avoid adverse events that you're going to have. For example, in Violet, we got around 70% of dry mouth because of this, and around 67% of anemia. Why? Because the energy is bigger. So then if we begin to get cleaner molecules to avoid how they are getting into these organs, so then this higher toxicity to the tumor cell gonna be a more target and more effective therapies.
Great.
It's the same with actinium. With actinium, it's the same. It's an alpha. But what is the biggest issue of alpha? Highly cytotoxic, but what happened with the salivary glands?
Yeah. Well, actually, it's a phase 1 trial. So we're looking forward to the next phase to see how terbium will help us on early settings, I hope. And I would like to ask, you talk about efficacy after and before chemotherapy. Do you decide how many cycles patients receive based on that? Do you are more likely to continue therapy even after complete response, to complete the 6 cycles in the patients after chemotherapy, and you decide to stop treatment earlier for the patients, for the good responder before chemotherapy?
It's a good topic and a good question because, when you are talking about after chemo, for sure, the number of cycles usually going to be between 4 to 6, no more than 6,
Yes.
usually no less than 4 because super responders usually doesn't happen in post-chemo. And why? Because there is evidence that after chemo, you could get around 35 to 40% decrease of the uptake of PSMA. So if you have almost 40 decrease on the PSMA uptake in these patients, so then the radiation that you are giving going to be less. And because of that, you will need more cycles. On the other hand, on the taxane native patients, is different. Actually, we have many patients that are the super responders, where after second cycle, they will have just one lesion, a little lesion. So then you will stop it. Usually not. I stop it after 3, and it's 3. And then if you have some little lesion, maybe you can complete it with ESRT, radiation therapy, completed and complementing that, because then it's not necessary. The lutetium is getting in and then it's getting out because all the lesions are done. So you don't need to continue.
So it makes us more comfortable to interrupt treatment before the 6 cycles completed.
For sure, because the affinity of lutetium that you have is higher, and because of that, the radiation is higher. And I can tell you that sometimes you can get 15, 20 grays per lesion in one cycle in pre-chemo, but after chemo, those numbers are not easy to get. And because of that, you will need more cycles.
Yeah. So after chemotherapy, would you recommend to do always the 6 cycles, regardless the response, because of this downgrade in the uptake?
I can tell you that continue with the cycles will depend on the imaging after every cycle, and then we're going to talk about it, and the lab that you're going to have. If you have some patient that the lab is going up, the PSA is going up after second cycle, third cycle, the patient is worse, and the imaging doesn't look so good, you need to stop it. Then, if the PSA is going down, the patient is a little bit better, but you continue seeing imaging after every cycle, you need to continue until you get the 6 cycles. No more than that. Until now, you cannot continue more than 6 cycles. And then in the middle, you want to decide how will you continue after lutetium with the treatment of your patient.
Right.
Rechallenge is also an option, but not approved. You can do it, but it's not approved. So I think that that's why in the patient's pre-chemo, the scenario is more interesting because you can even treat with less cycles when you have a complete imaging response, and especially also the lab. I have one patient that has 0.04 PSA and no imaging after 2 cycles. So then you're going to give one more, and what are you going to give him more lutetium because the lutetium is getting in and getting out.
Okay, makes sense. Great. And well, the last topic, it's a very good topic. You gave an amazing talk at ASCO GU this year about how would follow patients with bad PSMA and PSMA PET. And actually, we are staging much more patients with PSMA PET. And it's more difficult in Brazil, but in US, most of medical oncologists are following these patients with PSMA PET because they were staged this way. So, and you talk a lot about SUV mean. I don't have it on my reports, I have to say. In Brazil, we just have SUV max, but perhaps SUV mean would be better to follow these patients when you start treatment in this metastatic setting.
Okay. First of all, I'm going to tell you what is the magic of diagnostic. We treat what we see, and we see what we treat. Saying that, you're going to have some selection criteria that are going to give you information if this patient going to be good with lutetium or not. SUV mean is a good information, but you will not discharge patient because of SUV mean, but for sure could be a potential imaging biomarker. We know right now that with a SUV mean that is not per lesion, is a whole body SUV mean. With this technology, what you do is you scan the whole PET scan and you get a whole body SUV mean. And with a SUV mean below 10, you know that this patient may be going to be worse than the patient that has a SUV mean above 10. So this is just for selection criteria, right? Then in the follow-up, SUV mean will change for sure, but will not change your therapy approach. So SUV mean is just for the beginning of the treatment. After that, because prostate cancer group 3 right now said that you need to follow the patient with bone scan and CT, it's crazy that you are selecting patients with PET PSMA, that is a molecular imaging modality, and then prostate cancer group 3 tell you that you need to follow up with bone scan and CT. But remember that this prostate cancer group 3 was done in 2016. So it's almost 10 years of that. And right now there is a proposal that is being developed by Michael Hoffman and their team about this prostate cancer group 4 proposal that include PSMA as part of the follow-up. But remember something, Barbara, after every cycle, you can do an SPECT. It's free, it's over there, and you don't need to invest anything else. The patient, after doing the treatment, you're gonna put it after 24 hours in the gamma camera, and you're gonna do an SPECT for free because over there, you don't need to invest anything else. And with this imaging, you can also get the RECIPE 1.0 criteria. So then you don't need to do PET PSMA after every cycle or after 3 cycles because you have a molecular imaging exactly 24 hours after giving the lutetium. So right now, how I am doing right now in my practice is I select the patient with a PET PSMA. I consider the SUV mean as a potential biomarker. PET FDG, not in all the patients, in selecting patients. And when I said that I need to go forward with this patient, what is the next step? The cycle. And after the cycle, I do 24 hours SPECT-CT. And with this imaging, after every cycle, I can get the evolution of my patient. I remember that recently, actually, Louise Met from Australia, she said that this second cycle SPECT-CT, TTV, that is total tumor volume TTV after lutetium, could be a potential biomarker of progression or not. So then you can use this image that you have it from the lutetium treatment to really do the evaluation. Of course, conventional imaging is not logical because you are not seeing molecular, you are seeing morphological. You don't care about morphological when you are selecting and treating with molecular imaging.
Wow, oh, amazing. Great explanation. And well, I remember about a last topic. So the last one was not the last, actually. What about the combinations? So we're now seeing a lot of different combinations with lutetium with ARPIs, lutetium with different emitters. So what are the future directions on this landscape?
The future going to be the combination. The answer is what combination and how to do it. Some simple examples. ENSA-P, the rationale below ENSA-P is how ARPs could do an upregulation of the PSMA glycoprotein in the tumor cells. And because of that, with that rationale, if you give enzalutamide, it seems that many patients will have a more uptake as a radiosensitizer of the PSMA. So then you give enzalutamide, and then the uptake gonna be better. We have an off-label experience about that, especially with darolutamide. In some patient that he has some toxicity, liver toxicity for darolutamide. So we need to get to 50% the dose of darolutamide, but combine it with lutetium. And this was a super responder patient. Because of the combination, maybe. Because he was pre-chemio, maybe. Or it's because of everything of this. What's going to be a second combination? Going to be for sure the option with radiotherapy. In some patients, it seems that radiotherapy could be a boost for PSMA uptake. How long should be between the radiotherapy and the PSMA lutetium therapy? How many radiations? We don't have that information, but Luna trial is trying to develop this combination.
The radiation is before lutetium.
Before, because it seems that some hours before, radiation could make a boost of uptake of PSMA. So then you do the lutetium and the affinity gonna be bigger. So it seems that this combination also could be. With chemo, also there is look at something about that. I think that gonna be in the other scenario from my perspective. And then you will have also alpha and beta combinations. For example, actinium plus lutetium, that this kind of combination is gonna allow you to give less activity of lutetium, less dose of lutetium and actinium. And because of that, this combination could be better and better results, but with less toxicity. That's gonna be part of the future. Combinations of alpha plus beta, combination of beta lutetium plus ARPIs, and maybe in some patients, combination of chemo plus beta, that I think they're going to be on the last of the history.
Yeah, and it would be possible to combine terbium with the alpha emitter, thinking about to reduce the toxicity.
Yeah, but maybe remember that the thing is, for example, why is the toxicity of actinium? Because it's being fixed, it's getting directly to the salivary glands. So if the PSMA molecule that you are using with actinium or with terbium is the same and has the same affinity to this, you really resolve the problem. So the better way gonna be develop some PSMA molecule that have no affinity or less affinity to salivary glands, and then the problem is resolved.
Oh, great. Danny, thank you so much for all your insights here. I always learn so much from you, and it was an honor to have you here today.
No, Barbara, thank you so much. First of all, for inviting me to this talk. I really love this topic, and thank you so much for the time. And on the other hand, thank you so much for being part of Urotera Latam. It's an honor having you over there, and of course, Brazil being part of Urotera is essential, and oncology people being part of Urotera Latam is essential. So thank you so much for being part of this dream and this people just trying to do crazy education about diagnostic as a team.
Oh, thank you so much. It's an honor for me, and it's an honor for us in Brazil. Thank you, Danny.
And for sure, the next year, we're going to have our book in Brazil together with all of you.
Yes, great. Glad to be part of this.